This is our last So What seminar of the year, and we've got some great pieces of research to talk about with you. So just to give you a bit of a rundown, today we're in my bit, which is the introduction at the moment, and we've got 3 talks for you today. Journey is going to be talking to us about the CALO project, which is something that we've been collaborating on this year. So it's fantastic that she can join us and talk more about the work that they've been doing around a systematic approach to improving adolescent mental health. And then June Brown, who's been leading the BEST trial, can tell us about the results of that really exciting study. And Julian is then going to talk to us about gender marginalised groups and young people's mental health. And we hope we will have plenty of time for the panel at the end, which will consist of our speakers, but also our parent champion and young champion, who we'll ask to introduce themselves in a minute. And then, we'll wrap up by 7 o'clock. So that's the rundown. Next slide, please. So just to give you an introduction to who's in the room, can I ask all of those named on this slide to just maybe pop their camera on for a minute? I'm going to ask you each to introduce yourselves. So I'll just do it in the order that we have them here. So I'm Jess Dayton. I am Director of Applied Research and Evaluation at Anna Freud, and I'm also Professor of Child Mental Health and Wellbeing at UCL. And I'm Director of the Evidence-Based Practice Unit, which hosts these seminars. Julian, do you want to go next?
Thanks, Jess. Hi, everyone. Thank you so much for joining us this evening. My name's Julian. I'm a researcher based at Anna Freud in UCL, like Jess, and one of the main kind of areas I work on is about how we can empower young people and families to be actively involved in mental health, but also the kind of support that they get from mental health services, as well as being actively involved in how we do our research.
Thanks so much, Julian. Journey, would you like to introduce yourself next?
Yes, of course. Thank you, Jessica. So my name is Journey. I am a Youth and Community Participation Lead at Dartington. So what that means is just that I'm looking at every opportunity to ensure that communities and young people are front and center of what we are trying to do and are designing whatever we are trying to design to support them in their lives.
Thanks so much, Journey. June, would you like to introduce yourself next?
Hi, thank you. Hello, everybody. I'm June Brown. I'm a reader in clinical psychology at King's College London. And I'm the chief investigator of a trial that we've just finished, which is the BEST trial. My major interest is to do with early intervention for depression and anxiety. And it feels very much like there's a lot that we can learn about how we can actually reach out to young people and how we can actually offer them things that could be helpful. Thank you.
Thanks so much, June. Emily, would you like to go next?
Hi, thank you. Yeah, I am Emily. I'm a young champion, so a sort of lived experience participation volunteer. I've been with Anna Freud for about 1.5 years now, which has been great. And I'm in my 3rd year of uni.
Kate, to introduce yourself.
Hi, I'm Kate. I'm a parent champion, so representing parents' views. I'm a mum of an adopted boy of 4 years old, but I also happen to be a secondary school teacher as well. So sometimes I come at it from that point of view as well. I've been volunteering with Anna Freud for about 1 year as well.
Great, thanks so much, Kate. And finally, Martha.
Hi, I'm the Programme Coordinator for Applied Research and Evaluation here at Anna Freud, and you'll be hearing more from me when we get to the Q&A later.
Thanks, Martha. Great. If we can go on to the next slide then, we can just say a little bit more about what the Evidence-Based Practice Unit is about. So it's actually a collaboration across Anna Freud as a child mental health charity and the Faculty of Brain Sciences at UCL. And we see our role as very much bridging the gap between research and innovative practice in children's mental health. So that means a lot of what we do is very applied research, and we try to apply what we call the So What principle, hence the So What seminars, which essentially means that unless we can describe to somebody who's either working closely with young people or supporting them in other ways what the point of our research is, that's not an area that we will be working in. So we like to think that it has real practical relevance for what people are doing out in the world. So that's very much the territory we're in. We work very closely with the Child Outcomes Research Consortium, which many of you may have heard of. And their work is very much around that it's a membership organisation, and it very much focuses on how to collect and use evidence to improve children's mental health and wellbeing. And that's often working alongside statutory services, but voluntary sector organisations, schools, and so on, to see if we can use evidence to kind of orient our practice better to need and better outcomes. Great. And next slide, please. So every year, the Evidence-Based Practice Unit produces a key findings booklet. So that is just to try and distill some of our key learning from the year. It tends to be organised around 4 principles that we have. Not principles, themes really, which kind of describe the kind of territory we're working in, and that is risk, resilience, change, and choice. So risk might be about what puts young people at risk of poor outcomes in the context of mental health, but also how experiencing mental health challenges might also have knock-on impacts on other aspects of life that we would want to prevent those impacts. So it's thinking about those things. Resilience is about how we can introduce protective factors that support young people to thrive even in the context of risk, and that might be supporting the young person directly, but it's also about creating systems around young people that are resilient and support them effectively. So that means resilient schools, resilient communities, and so on. Change is about how we can understand sort of developmentally and over time how mental health is shifting, you know, as sort of year-on-year trends, but also developmentally for young people, what happens through the course of childhood, adolescence, and into early adulthood. But it's also about change in response to support, treatment, intervention as well, and that means evaluating what might be the effective practices to support children and young people. And choice is really around empowering young people to make decisions around the support that they can access, but also to give them a voice in the research that we're doing and a really prominent role in the work that we're doing in terms of research and evaluation. So those are our sort of key principles, and those are the prongs we hang our sort of key findings on each year. We're keen to not just amplify the work that we're leading ourselves, but also the collaborative work that we do with colleagues in other organisations, because a lot of that work is, you know, when we put heads together in this space, this is where we can really generate really rich learning. So we're really happy to have some examples of that collaborative work being led by others being described today. Great. And just to say that key findings summary for this year just came out on Monday. I think the link will be going in the chat. So please do take a look. It will give you just a taster of the kind of things that we do. And our Twitter feed has lots of other information, as do the Anna Freud and UCL EBPU web pages. Great. Okay. Well, I think now we should probably move on to our first talk, which I will hand over therefore to Ajani to introduce herself and tell us more about CALO. Thanks, Ajani.
Thank you again for the intro. So just again, my name is Ajani and I work for Dartington. I forgot to talk about what Dartington is and just assumed everybody would know, but we are a charity based in the UK, and we are looking to improve outcomes for young people in different ways. And we are particularly interested in what we call systems change. So we are particularly interested in changing the conditions that keep particular problems in young people's lives in place. And here we are talking about policies, actors, different ways that people think that might be holding particular problems in place at the moment. Should I just say next slide, please? So there's just the introduction. Next slide, please. So what CALO is trying to solve? I just noticed that this slide needs to be updated in terms of the percentage that we have now, but we are looking at the changes in young people's mental health that are happening right now. So we are looking at that, and we have been very concerned about those changes, but also we are looking at mental health inequalities. So the things that are happening right now are not happening in the same way for all young people. There are inequalities for young people due to situations of poverty. When you look at young people that belong to particular groups, for example, LGBTQ plus young people or racial minoritized young people, children in care. So yeah, so we are looking at adolescent mental health, but we are also looking at health inequalities within that. Next slide, please. So what is CALO? CALO is a program, as we're saying, that is concerned particularly with the root causes of adolescent mental health. So what that means is that we want to be looking at what we call the social determinants. That's how we are looking at this. So for example, we are looking at unemployment, we are looking at the situation of somebody's neighborhood, conditions of poverty, for example. So we are not looking at the problem after it has already happened and looking at treatment, even though we think this is very important and there are people out there doing that. We want to be looking at prevention, we want to be looking at what we can do before that, look at the social determinants. CALO is also concerned about doing that with communities. So we want to explore, we want to create, and we want to collaborate with communities in order to build the solutions that we think are going to work to address those issues. And by communities here, we mean particularly young people in this case, but also their parents and organizations working with them. Next slide, please. Thank you. So CALO actually has various phases. Today, I'm just focusing on sharing with you the outcome from the early discovery phase, as we call it. This phase, in a few words, involved understanding what matters. So we went to ask young people, what matters to you in terms of mental health, where you live. So CALO is happening in 2 communities, in Northern Devon, which is a rural, more isolated community, and in Newham within London, which is like a city and dense area, very racially and ethnically diverse area. So this is more about the outcomes for that early discovery phase. But I'm also letting you know that based on what we found in the early discovery phase, and young people have told us and communities that we need to focus on, then we went to co-design responses with young people and communities to solve those issues. And now we are in the implementation phase. So we are implementing with young people and communities the solutions that they have designed. Next slide, please. Thank you. So within CALO, as I said, I think I've been saying this a few times, we want to work with communities and young people. So we started in the early discovery phase, which is what I'm going to describe the results of today, with a lot of participatory approaches. So people were very involved, but there were many decisions that we were still making as a consortium, as CALO. And CALO involves many organizations, including Anna Freud. So there were still many decisions that we were making and bringing into that space. In the co-design phase, then we were working with communities a lot more. So we were co-designing together solutions. And now the communities are implementing, but we are supporting, for example, with resource acquisition, looking at how we learn from what is being implemented as well. Next slide, please. So these are all the organizations, as I mentioned. I'm just the individual presenting here today, but a lot of people have made this possible, and people from all these organizations that you can see there on your screen. Next slide, please. So what did we ask young people in that early discovery phase that I said that we wanted to understand what matters for them? We asked young people a few questions that were going to come up afterwards in the slide. I just realized, sorry. But first, I'm just going to say, so we spoke with 178 young people in Northern Devon and Torridge. This is the whole area of North Devon. Sorry. And this is not the population of young people that you might find, for example, in Newham. So this is quite a big number of young people that we spoke to there. We spoke to young people in park, streets, schools, youth centers, libraries. Wherever they were, we went. Sometimes we would travel to villages that had maybe 2 young people living there because we kept asking people and knocking on doors. But that's what we wanted to make sure that all young people were heard in those spaces as well. So we were going there to have them represented in everybody that we were speaking to. We also, of course, had a lot other aspects of diversity that we were concerned about in speaking to those young people. We also distributed flyers in order for young people to respond to a survey in case they couldn't speak to us. Sorry, next slide, please. This is just so you have an idea on a map where we went to speak to young people. The whole area in the north, that is Northern Devon, and these are all the places that we went to and all the organizations that were also involved and that we spoke to. So as you can see, there was a lot. There was a lot of walking, a lot of caravans, a lot of travel everywhere. Next slide, please. So these are just the examples of the questions that we asked. We asked, what is it like to live here as a young person? What matters for you in living here as a young person? And then what do you think well-being means in terms of living here? Next slide, please. So the next slide just has a few of them, so I won't go through that because I don't have a lot of time, but it's just so you can see a little bit of the key words, themes, sentiments that were coming from that question. Next slide, please. From the other question. And then the next slide, please. And finally, the next one. As I said, we also spoke to community members to understand this, not just to young people. You can see there in the photo, it's just me with the caravan that we used to go to many different places. But we spoke to all of them as well. And as you can see there, 46 plus organizations. It's funny because we spoke to someone about the organization in Northern Devon, and they said, oh, I think there are just 46 organizations in Northern Devon, so we have spoken to everyone. But we were interested in the big organizations, the small organizations. We spoke to everybody that we could. The next slide, please, just show some of the questions that we asked them as well there. So out of all of this, we wanted to get to what are the key themes and the key things that people want to change in this area. Next slide, please. Which we called opportunity areas. So what were the opportunities that we had in that area in order to improve young people's mental health? Next slide, please. Here is the list of the first opportunities that we had. You can see that there were things around being accepted, supported, and feeling like they belong to communities. This was particularly important for young people that were living in very remote areas. And maybe there were other 5 young people that they knew for miles. And it was very hard for them, as they would say, to be themselves in those spaces and find things that were made for them. They also talked about the transition. Both types of transition. For the younger young people were about transitions to teenage years and all the changes that were happening with your body in where you were going and what that made them feel and how that made them feel. For others was about the transition to adulthood, so entering employment, having to choose a career, not having opportunities very close to their homes, having to travel to very far away in order to find employment or studies and what that caused for them as well. There was also something about mental health awareness. Many young people wanted us to be thinking about, they wanted to have a community that was mental health aware and that had the literacy and the strategies to support them. So we talked about that as well. They talked about being able to access diverse opportunities as well. Again, because this was in a very rural community, there are many opportunities that young people don't have access to, and because of many different reasons. So they wanted to talk about that and see how that problem could be solved. They also talked about not having equal access to different things. So for example, some young people would say, I live very close to the beach, but I haven't been there yet because I can't pay the bus, or because my parents can't drive me there, or because I don't know how to get there, I don't know how to swim. So just having equal access to places and spaces. Being supported by families, by their family, parents, and carers. And also about having consistent and connected approach with organizations. This was about, or young people mentioned to us that sometimes they would look for support and they would have to retell the story of their lives, or some organizations would be completely disconnected to what was happening before, or they would work sometimes against each other, as young people told us, and they would like those systems of support around them to be more connected. Next slide, please. So we went through prioritization activities to see together what would we have to prioritize and co-design together solutions for. Next slide, please. And those were the 3 things that young people particularly, but community members also decided that we had to prioritize. Feeling accepted, belonging to a community and being supported in the community that you live, accessing diverse opportunities, and having a community that's mental health aware and has the strategies and supports required to support those young people as well. I think I added one more slide, but we don't need to talk about that. I was just showing the priorities from the other site in London. But as I said, the focus of this presentation is more Northern Devon. But yeah, thank you so much for listening.
Fantastic. Thanks so much, Jenny. It's really impressive to see a genuinely co-produced piece of work. I don't know if I'm more impressed by your nomadic lifestyle trying to get all of those views, or, you know, the quality of the kind of process you've gone through there to highlight some of those issues, and some of those certainly chime with what we've heard young people talking about as priorities too. And interesting to see the Newham, as a comparison. Thank you very much. Next, we're going to move to quite a different kind of intervention. June is going to talk to us about the BEST trial and the findings that are fairly hot off the press. Thanks, June.
Thanks very much, Jess. Thank you for inviting me to this really interesting seminar. I was wanting to talk about the results of the BEST trial, and as Jess is saying, we've just been finishing off the trial, and I need to also say Jess has been an invaluable part of the trial, so I'm very grateful to her in terms of her work on this. So let's have the next slide, please. So the name of the trial was the BEST trial, and it started in January 2020, just before the pandemic, and it's finishing this year. And the main aim of the trial was to investigate the clinical and cost effectiveness of day-long stress workshops on symptoms of depression in 16 to 18-year-olds. So we compared those who received the workshops with treatment as usual at 6 months follow-up. And importantly, we also wanted to know about the accessibility of the workshops for underserved populations. So it wasn't just the normal students who might come forward, but we really wanted to focus on the underserved populations, and particularly the people from ethnic groups. Okay, next slide, please. So I'm going to use all sorts of different terms, and when I was doing a presentation, somebody said, maybe it might be useful to actually just explain what the different terms mean. So the BEST trial refers to an evaluation of the day-long Discover stress workshops, and Discover refers to the workshops which use an evidence-based CBT approach to help students manage their stress better. And each workshop can take up to 19 students. And in this national trial, we plan to enroll 60 schools and 900 adolescents using a self-referral system to recruit participants in 4 regions in England. So can we have the next slide? This is a map which shows where we were. So in the northwest, up the top, that's Jess's region, northwest. In the middle is West Midlands, but we also covered East Midlands. And then in the bottom left-hand corner, it's the southwest, focusing on Bath. And then there's London to the right. Okay, next slide, please. So, as you all probably know, the proportion of young people with mental health problems has increased a lot. So these are the figures for those aged 17 to 19 with a probable mental health condition, and that went from 17.4% to 25.7% between 21 and 22. And the BEST trial has sought to address some of the existing barriers to young people accessing help. I need to also try and answer the question about how come schools, because initially we weren't sure where to run the workshops. So we tried a number of different venues, including leisure centres, youth clubs, and so forth. And through a bit of trial and error, we actually found out that young people wanted to actually have an intervention in schools because that's where they spent most of their day. And so we've run 3 trials now in schools, and the BEST trial is really the culmination of all that. Okay, so next slide, please. So what I think we have are 3 probably different kinds of problems. And what I want to do is just in the left-hand column, highlight the problem, and then in the right-hand column, explain a bit about how we've tried to handle the problems. So we know that young people don't seek help very readily because of concerns about stigma and confidentiality. And they also have a limited knowledge about mental health. So that's a biggie. And that's been in the literature for a long time. And so what we tried to do in the BEST trial was we used a model that I developed. It's called the PLACES model. And it's very much about trying to improve access. So it's about improving access for young people, but it's also for adults. And what we did was we used colloquial terms like stress rather than medical terms like depression or anxiety, really to reduce stigma. So this was very much about positioning mental health as a problem of living, as opposed to, oh, it's a big medical problem that you really need help for. So that was the first. The second was about using self-referral. It's encouraging students to come forward themselves, encouraging them to be autonomous. And we know that young people and adolescents particularly like this. And it's an unusual approach, but it made sense in terms of us trying to say, look, how are we going to encourage people to come forward and receive help? So self-referral was a major part of this model. And the third part of it was about just having very brief interventions in convenient places. The logic of this is that if you have an inconvenient intervention, so if it's a weekly session somewhere in a mental health hospital, it's very unlikely to be used. So the original workshops that I ran, they were day-long workshops in leisure centres, and people did come. So, it's just important to just think about convenience. What is it that people will come and use? And sometimes we in the services might forget that point. Okay, can I have the next slide, please? So the other major problem was that it's estimated that 60% of children and young people with a diagnosable mental health condition don't receive any care through the specialist services. And it's to do with a capacity problem. And what we did in the BEST trial was we worked with a new workforce called the Mental Health Support Teams. I'm sure you've heard about this because Peter Fonagy was very much behind the development of this. And mental health support teams have been recently introduced in the UK to support young people's mental health and bridge the gap between schools and camps. So they've been introduced to support young people aged 5 to 18. So it's a big age group to cover, but that's the remit. Next slide, please. And the third problem was to do with problems of engagement. We know young people don't always continue to engage with services, and services may be affected by poor take-up and high dropout, e.g. some digital services. So sometimes we've had digital services and they just are not taken up by people, or so people may take it up but then drop out. So what we wanted to do was we wanted to use an intervention that young people would use. So Discover was co-designed with 16 to 18-year-olds who named the intervention Discover. So they decided that that should be the name. It was nobody else's decision, it was their decision. And the workshop matches young people's preference for more practical, interactive, and brief help. So what they wanted was something that was short and sharp. Okay. Next slide, please. So those were the problems. Those were the ways in which we tried to deal with the problems. So in the top bit, this is a summary of the BEST trial and the steps that we took. So as I said, it started in January 2020 and it's finishing this year. So we had the Discover Stress workshops there. We tried to make them accessible so that people self-referred and they had normal names. They were brief. They were co-designed with young people. And then we had 15 mental health support teams in 4 regions in England. So I said it was the Northwest, Midlands, Southwest, and London. There were 26 workshops, 900 students in 57 schools. So the 900 students in 57 schools were those in the trial, and half of them got the workshops, and the other half got treatment as usual. Okay, next slide, please. So this is the beginning of the results. So we found that we had a really good follow-up rate after 6 months. So we had a 96% follow-up rate. So 96% of the 900 actually responded when we asked them to come back for a follow-up at 6 months. We had a very diverse group of students, with 46% of students from non-white British groups. So they were largely Asian and Black students. Only 20% had previously sought formal help, and 88.5% attended 75% or more of the workshop. So inevitably, because it was a day-long workshop in schools, some of the students would say, oh, I need to go off to a class, or they needed to do other things. But we had 88.5% actually attending 75% or more of the workshop. Next slide, please. So this is the first slide showing pictures, and I'll try and explain what the pictures mean. So what we were trying to do was measure depression or low mood, and we compared 2 groups. One was the control group, which is the group in blue, and the group in red is the Discover workshop group. What this shows is that after 6 months, the Discover workshop group became a lot less depressed, reported fewer depression symptoms at 6 months compared to the control group. Okay, and this equates to a kind of small effect size of minus 0.17. Next slide, please. And this next slide shows the results for the people who might be seen as having elevated symptoms at the beginning. So these are people who might in other settings be seen as having more clinical symptoms of depression. And what this shows again is that the control group with the dotted line improved less compared to the Discover group. So going down is actually a sign of improvement because you've got fewer depression symptoms. And we had an effect size of minus 0.52, which is actually a very impressive effect size. Next slide, please. So where next? So we are presently doing a 2-year follow-up with the students. We want to know whether or not this 1-day workshop actually leads to sustained results. So we're on the point of actually discovering whether that's the case. Secondly, we've just been awarded 1.8 million from the NIHR HSDR to research how we can implement the rollout of the workshops across the country. So this is on the basis of some very promising results that we've had and which I've shared with you, showing the clinical effectiveness, and also the cost effectiveness results were also very impressive. And then the MHSTs could help us roll out the Discover, because they're already funded in a third of the areas in England, with plans to expand them to 50% of areas and then 100%. Okay, where next? Right, next slide, please. Right, so just to say thank you to the HTA for funding the bus trial. As I said, it's finishing this year, and the paper is published in the Lancet Psychiatry. And next slide, please. So this is the final slide, saying for me to say thank you to everybody who was part of the BEST trial. It's been a fantastic group to be part of. Jess's name is there. Aisha's name is also there because she was the research worker up in Manchester with us. We also had 15 workshop delivery teams across the country and 57 school staff teams and 900 participants. So that's it from me, and let me hand over back to Jess.
Thanks so much, June. Such exciting findings. A brilliant team, but expertly led by you, and really exciting results in terms of the impact, and also in terms of the reach to groups. 80% of those have not received support anywhere else. It's really nice to see that when we kind of do think about the perspective of young people about where they want to access help and how it can really reach people who need it, who perhaps haven't had that before. So yeah, very exciting.
Yes.
Some of you may have signed up to the workshop that gives more detail about this trial on Friday. I think it's now sold out, June, right? So
Yes,
there's now a
yes, I
waiting
gather
list.
so.
But
There's a waiting list, I gather.
yes, I think that's right. But so hopefully some of you can join for that. But you can also read the paper. So yeah, thank you.
Okay.
Great. Thanks, June. Right, so we're now going to move on to Julian, who is going to talk about perhaps other groups that are sometimes marginalised or not properly reached by our research and our support. So Julian, over to you.
First of all, thank you, Ajani and June, for a couple of really interesting presentations. And yeah, a huge thank you everyone for coming and being with us this evening. So I'm going to be talking about a paper that we've recently published, and colleagues are helpfully going to put it in the chat so you can have a look for it yourselves. And this is where we were interested in looking at the relationship between different characteristics, particularly gender and groups who might be marginalised or minoritised. And we wanted to look at how these different identities were related to mental health for young people. And we were particularly interested in people's patterns of mental health over time, or their kind of trajectories of mental health. So yeah, I mentioned we recently published the paper that also has all of the references I'll be referring to today. And I wanted to say a thank you to my colleague Tanya Liera, who led this work and also developed the slides. And finally, I'll be using language that we've agreed in our group about marginalised groups, equity, diversity and inclusion. But there are kind of different and ongoing views about language. So yeah, really welcome people's feedback and the chance to think this through together. Moving on to the next slide, please. I just wanted to add some acknowledgements, and first of all to say a huge thank you to all of the children and young people who contributed their data that I'll be talking about today. I want to thank the Head Start project, and you can see more about them on our website. If you Google EBPU, you can find a link that talks about our different projects. They provided us the data and were funded by the National Lottery Community Fund. And then finally, I'd like to thank the National Institute for Health Research Programme for funding the body of work. And this analysis I'll be talking about today was part of that work. Moving briefly on to the next slide, as we've heard about today, we're concerned about the kind of increasing levels of difficulty we're seeing for children and young people. And we were interested in the role of gender disparity. And this is a pattern that we unfortunately do see across countries, where young women are about twice as likely to experience some types of mental health difficulties than young men. And on the next slide, we know there are many possible drivers about what might be causing this gender disparity. And we kind of illustrate a couple of examples of these on the slide, but these include things like heteronormative gender role socializations, different societal views and attitudes toward gender equity, what it is, how much it should be prioritized. But also we can't forget the societal structures that work to perpetuate gender inequity. On top of the role of gender inequity, we were also interested in thinking about ethnicity and other marginalized or minoritized identities. And moving on to the next slide, this theory, minority stress theory, helps us to understand how these different identities might impact individuals' experiences. So it starts off by saying, as we know, individuals from groups that are marginalized and minoritized experience increased stress due to discrimination and inequity. And clearly, it's important that it's not the membership to those groups that is causing this stress, but the systemic discrimination and inequity members of a group will experience. For individuals who belong to multiple groups that are marginalized and minoritized, we know these individuals experience higher levels of stress, but this higher levels of stress is kind of greater than just the sum of the stress of the individual identities to which they might belong. So yeah, minority stress theory is kind of helping us to think about the impact of these individual identities that might be marginalized or minoritized, but also the impact of kind of belonging to kind of multiple of these identities. On the next slide, we just summarize what we were interested in this particular study. So as I mentioned, we were interested in looking at patterns of mental health difficulties over time. And the time frame we had available in our data was a 3-year period. So we wanted to look at a few different areas. First of all, we wanted to see if young women and girls were more likely to have patterns of high mental health difficulties over time, and indeed if their mental health difficulties appear to be worsening over this 3-year period. We also wanted to see whether other groups that tend to be marginalised and minoritized also experience similar patterns of high levels of mental health difficulties and worsening mental health difficulties over time. And finally, we wanted to begin to explore the intersectional effects, particularly related to gender and belonging to kind of other groups that might be marginalised and minoritized. Moving on to the next slide, please. We just kind of summarize the data we looked at. So we were fortunate to have over 14,000 children and young people. And this sample included those who completed a survey when they were about 11 to 12 years old, and they completed at least one additional survey that was either a year later or 2 years later. Our main focus was on the Strengths and Difficulties questionnaire, which looks at emotional difficulties and behavioural difficulties predominantly. And we had a range of other socio-demographic characteristics that we took through linking the data that we had from the SDQ surveys to the National Pupil Database. So we had a range of other demographic characteristics. We also had supplemented these demographic characteristics with self-reported gender identities, and this was available for a subgroup of the sample who had completed one of the later surveys where we had asked about self-reported gender identity. Moving on to the next slide, I'll just summarize the analysis that we did. And here, what we were interested in is trying to identify groups of children who had similar patterns of mental health over time. So we were interested in identifying groups of children who had kind of similar levels of mental health difficulties and similar kind of changes over time. And we identified these kind of 5 groups that I'll talk about in a moment, but we saw quite similar patterns in the different mental health difficulties we looked at. So in emotional difficulties, behavioural difficulties, and total difficulties. So we saw quite similar patterns over the 3 years. And just to break down what these patterns were, on the next slide, we kind of zoom in to have a bit of a closer look. So going up on the y-axis, we can see the levels of mental health difficulties, which here we have the total difficulty score. Higher scores indicate higher levels of mental health difficulties. And then going across on the x-axis, we have the 3 school year groups, so the 3 time points where we had data. So going from kind of top to bottom, we had five of these different patterns. So in the top line, we had young people who had high levels of difficulties, and these difficulties remained quite consistently high over the 3 years. In the next line, we had those young people who started off with medium to high difficulties, which decreased somewhat over the 3-year period. Then we had those who had medium levels of difficulties at the start, which increased over the 3 years. Those with medium difficulties that remained kind of medium over time. And finally, those with low levels of difficulties, which remained quite low. In the next step, what we were interested in was looking at which characteristics predicted who was going to be represented in each of these 5 groups. So dipping quickly into the next slide, this just gives a kind of overview of the findings for this next step of the analysis, but I'm going to cherry pick a few findings because we have quite a few here. So the graph in the next slide is showing us, looking at emotional difficulties. It shows us how likely people were, with the characteristics on the left of the slide, were to belong to each of these different groups, to belong to the medium increasing pattern, the medium stable, high decreasing, and high stable patterns. And all of these kind of group memberships are compared to the group with low stable mental health difficulties. So it's looking at, in the first column, those with medium increasing difficulties compared to those with low stable difficulties. So it's telling us kind of how likely people were to have worse patterns of mental health difficulties over time. So what we can see looking at the first row is that young women and girls were more likely to be in all groups with worse patterns of emotional difficulties over time than they were to be in the low stable group compared to young men and boys. And they were particularly likely in the right-hand side of the screen to be in the group that had high difficulties, which remained high. On the next row, we can see that children and young people with non-binary or questioning gender identities were also more likely to experience higher level of higher levels of difficulties compared to young men and boys. But I have to note here we had a smaller number of respondents identifying with these gender identities. So the confidence in some of these findings is a bit more uncertain. In the next slide, we have the same thing, but this time focused on behavioural difficulties. And this is showing us that young women and girls were less likely than young men and boys to have high levels of behavioural difficulties. The other point I wanted to highlight in this slide is that if we go down to the last few rows, we can see the impact of free school meal eligibility, special educational needs, and child in need status. And children with any of these indicators were more likely to be in groups with higher levels of behavioural difficulties compared to the low stable group than those children, young people without these indicators. And this pattern was actually quite similar when looking at the emotional difficulties and total difficulties as well. Moving on to the next slide, we then try to explore the intersection of different needs. So we looked at free school meal eligibility, special educational needs status, and child in need status. And essentially what we found was that the impact of these needs was quite similar for young women and girls and for young boys and men. So there didn't appear from a statistical perspective to be an additional impact on mental health difficulties of, for example, having free school meal eligibility and being female beyond the individual impacts of free school meal eligibility and being female. But again, I have to point out that this is purely from a statistical perspective. I'm over my allotted time, so we have a summary of the results on the next slide, which I will move over. And then if we look at the slide after that, we just highlight some of the key recommendations that we took from this study. So the importance of having tailored mental health support for vulnerable groups, mental health programs that address the compounded effects of experiencing multiple disadvantages, the importance of having safe and inclusive schools, culturally inclusive mental health assessment tools and support programs, the importance of early intervention programs, but also the importance of having support for families of vulnerable children and young people. So that just leaves me to conclude on the next slide by saying thank you for listening. Hopefully that gave you a bit of a flavour of what we did and in the study and what we learned from it. And yeah, please do check out our paper or get in touch if you want to talk about it further. Jess, I'll hand over back to you. Thank you.
Thanks so much, Julian. Really interesting findings, quite beautiful graphs as well, but really interesting to see those intersections there. Right, I think we are now onto our panel session. So if I can ask to, perhaps we just park the slides for now, and if I can ask those who are joining the panel to pop their cameras back on. I will hand you over to Martha, who's going to chair this part of the session. While we're just doing that, can I just remind people of the Q&A function? So you won't be able to pop your hand up. So please do put some questions in the Q&A. And we'll pick them up as we go through our panel session. Martha, over to you.
Hi. Well, first off, I want to say a massive thank you to everyone on the panel. That was absolutely brilliant. There's so much really interesting information. So I'm just going to give people a few minutes to process some of that and pop some questions in the Q&A, but that means I get to you first. So I think what I'd like to do is maybe give the speakers a bit of a break, and I'd like to turn to Kate and Emily to get their sort of thoughts and feelings and maybe some of their questions for the panel on what they've just heard. So Emily, if you don't mind, I'd like to come to you first.
Yeah, of course. I think I'll go in order of how they were presented, if that's okay. Is it Kalo? Am I pronouncing it right? I forget every time. Yes, yeah. I love this one because I found it so refreshing that you focused on the Southwest So I'm from like the rural southwest, and I feel like it's such a like forgotten and left behind region. And I think as a young person, like it can feel so isolating. I'd never sort of, encounter the sort of research that you're doing, and I think maybe you'd be more likely to if you were located closer to like a university city. So that was really nice to see, and I think that sort of urbanicity and mental health is definitely, or has definitely been under researched until now. I guess one of my questions that just came to mind, and it might be too early and maybe you were just focusing on North Devon, but I know that in terms of services, at least where I'm from, I grew up on like a county border of like Dorset, Somerset and Wiltshire, and everything was very much county specific. So even though I lived in one county, went to school in a different county, services weren't joined up at all. So even though I might have lived 10 minutes away from somewhere, I would have been only eligible to access somewhere that was perhaps an hour away. So I don't know if you'd consider that. Obviously, it's not applicable to every setting, but yeah, just wondered if you had any thoughts.
Martha, should I go?
Yes,
So-
please do.
Definitely, and thank you for highlighting that as well. The young people also mentioned that, like, not having people come and talk to them about those things, and community members too. Yeah, and I forgot to say how much we are grateful for all the work that they did and that people could continue to do in Northern Devon to make this work possible. And in relation to what you said, actually, this was one of the things that people want to focus on, like joined up services. When we initially did when we were discussing those opportunity areas and the priority for the area, one of the things that stopped us from doing that then was that the program was focused only on the social determinants of mental health, and that didn't fit in those social determinants. But of course, we had to find a way around. So now in the implementation stage, a lot of the conversation is around what you just mentioned. For example, when we talked about Northern Devon, we were talking about two counts. We were actually talking about Torridge and North Devon. So now we are talking a lot about how do we improve joined up approaches in that area based on the things that we are trying to focus on with young people, which now are on unemployment, particularly in that area, and mental health awareness. So yeah, I can't give you an answer. We have done it, and I don't think we'll be able to give that answer necessarily, but it has definitely been something important for members of the community, and we are definitely focused on that as well together. Thank you for the question too.
Yeah, that makes a lot of sense. Thank you.
Thanks, Emily. I'm sure we're going to come back to you later again. But Kate, I was wondering if you wanted to jump in with any questions now, and just to remind people to pop anything else in the Q&A function as well.
Thank you, everybody. It was really interesting. Maybe because I'm a teacher, I've sort of my interest has peaked in terms of questions for June. Firstly, I couldn't work out what HSDR stood for. I worked out the NIHR bit, but not the HSDR bit.
Sorry, we were just using all these terms. HSDR is just to do with health service delivery research.
Okay.
So it's just a funding body which decides on how they're going to distribute money that they have for research.
Okay.
And the money that they have is much more applied. So it's very much about trying to see whether or not some of the research ideas might be put into practice and how they might be implemented.
Okay. And then my other question was, well, sort of a two-parter. The program, the Discover program, what was it? I couldn't quite work out. Was it delivered by the mental health support teams, or was it delivered by school staff as well?
It was delivered by mental health support teams. So they were trained by the Discover specialist teams, but it was essentially by these clinicians.
So my follow-up question then is, could it be that the school staff get to have that training as well, or was it very specialist training because I'm just wondering, obviously we all know the obstacles for young people's mental health provision is, funding, time, access, etc. And I really liked what you said about how young people feel that school's a really good place to access support. And that makes me feel good about being a teacher. But yeah, I was just wondering, is there a way that this can then be like rolled out through schools? Can it kind of be cascaded, or is the training that's needed too specialized?
Well, this is quite a tricky one, because a lot of the interventions to all the students in schools can be distributed by teachers. The only thing is that when you actually look at the literature, when the interventions are delivered by teachers, it's marginally less effective. And there's also literature to show that teachers might feel quite stressed, because if they're trying to deliver teaching as well as deliver therapy,
right,
it can be a bit too much.
Yeah.
So the beauty of the mental health support teams, which Peter Fonagy was very much behind, is that these teams are going to be linked to all the different schools in England. So this is an English initiative. It's not for Scotland, Wales, and Ireland. But in time, we should have mental health support teams linked to all the schools. So that's why we're focusing so much on this group, and they will receive the clinical training.
From a teacher's point of view, that's really exciting, because obviously we're used to these massive wait times for CAMHS, and we've kind of got to hodgepodge things in school while we're waiting for pupils that can be in crisis or whatever. So that's like really exciting.
Great. I'm glad that you think that. And glad that you're not going to say, oh yes, you're taking away something from us. But no, I think that's really helpful. So thank you.
Good questions from everyone so far. Okay, I'm going to give someone in the Q&A a chance now. So Bryony has a great question, which I think you're all going to have plenty of answers to. So I'm going to pose it to Julian first, but this is for any of the speakers. So what was an unexpected challenge, if there were any, of carrying out the research that you just talked about, and how did it affect your approach?
Yeah, thank you. I think that is a really good question. I think one of the kind of challenges we encountered is, obviously we had a real focus in that piece of work about looking at kind of groups who are marginalised and minoritized. And we know that the kind of how we go about doing research can unfortunately replicate those patterns of marginalisation that groups experience. And one of the kind of ways that can kind of manifest is it can be quite difficult statistically if you've got a kind of a smaller number of responses from one group, but a lot of responses from people from another group. So as I mentioned, when we were looking at gender identity, those with kind of non-binary or questioning gender identities were a much kind of smaller group in our data than those with kind of male or female identities. So we had to kind of think really carefully about kind of how we can manage this. How can we kind of maintain our focus on representing these groups whilst kind of still kind of taking these statistical considerations into account. And we were able to kind of include them in the main analysis and just kind of have this note about smaller groups. So I think, I think that was kind of one part of the challenge. I think the other part of that challenge is when you're then kind of looking at people with who have kind of multiple identities that can be marginalised and minoritized, that just kind of exacerbates the challenge. So particularly in that last part of the analysis where we were trying to look at the impact of these kind of belonging to multiple groups, we were kind of really kind of mindful that actually, some of the things we might not be finding might be because of this issue. I guess the final kind of part related to this challenge was thinking about kind of how we ask young people about their gender identity. And we were really fortunate to have this kind of self-identifying question in the survey. And this was a kind of free text response, which was great. And then we had the kind of challenge of, okay, how do we interpret what people have told us? And we were really fortunate in this body of work to be working with a charity, Gendered Intelligence. And it was just fantastic to be able to kind of go through what people had written with their expertise, but also with our peer researcher, a young person. So we could kind of work together to make sure we're kind of interpreting this information in a way that's still going to be authentic. So yeah, that was a kind of a cluster of challenges that we encountered.
Eloquently put. Thank you, Julian. Ajani, I'd like to sort of pose a similar question to you around the sort of any unexpected challenges. And I know that in your presentation, we were very much focused on the kind of Exeter, North Devon, side of things. It would be really interesting to get a sense of how that worked in concert with the other area that was part of the project that we spoke less about, maybe, if that's okay.
Definitely. When I saw the question, I was like, what challenge? There were so many things. There were opportunities for us to change direction in this project. But I think one of the things that not so unexpected, but it was a challenge across both sides, was ensuring that when young people were speaking, they were heard. So one of the things that we wanted to do was that, like, sometimes people might be thinking about, we need to prepare young people to be in different spaces. And of course we do, but we also need to prepare the adults in the room and the professionals to understand that this is a project where we are all trying to build this together. As much as we didn't want that to happen, there were moments that were difficult to be able to ensure that minimum, that we are all here to contribute to this. And we want to make sure that young people are heard and that actions are taken based on what they are saying, and making sure that that was happening the whole way. Even now, it's still challenging in different spaces. And some might assume that this might be just because people don't want to do that, but that is not necessarily what we are talking about. It's about all the structures that we have, and thinking about, okay, this is what young people want to see, and this is how young people want to see this. How do we make it happen with young people? But then you have policies, you have different ways that people are thinking about things. You have, a whole institutions, the way that they are working. And sometimes people, as much as they want, it's hard to move things around. And that's the thing that has been the most challenging for us, to try and ensure across both sides. That was also something that was surfaced in NEWAM by the community professionals as well. It's just not just me saying that. It's not just us from KALO, including Anna Freud. It's also community professionals saying it's so challenging to ensure that what we are hearing turns into action in different spaces. That has been one of the biggest challenges. But we continue to try and address this. And in our project, we have done this in so many ways. Like, for example, when we went to speak to young people, we first thought that we were going to include just North Devon in our research. And many young people and community professionals talked about how they shared different challenges and different things with Torridge as well. So we expanded the area. We also wanted to facilitate workshops and things in the city centers to begin with, because we thought that would be easier for young people to come into those spaces. Actually, young people told us, no, we need one of these to be happening in a city that is smaller or in a village, so that people can also go there. We need taxis to be able to access places. So, like, from smaller things to bigger things, we're really trying to ensure that what young people say is turned into action. But this is challenging in different ways.
Thank you. That was a really helpful kind of flavor of some of the different things and how you address them. So thank you for that. June, I do want to hear about the challenges of BEST, but I have some very specific BEST questions. So I'm going to save those for a sec, and I'm going to just spin it round to Jess, because I feel she's had a break for long enough. And I think, Jess, it would be really good to get your reflection on kind of everything everyone said, because I think there's a general theme with all of these different pieces of research and all these different projects around marginalized and minoritized groups and how they're showing up and how these projects kind of geared towards them and what we're seeing. And that would be really helpful given that we're kind of thinking about the year and sort of the work in review with the key findings and everything. And then we'll come back to June with our super specific best questions from the Q&A.
Brilliant. Thanks, Martha. Yeah, I think what's really standing out to me about all of these projects, although they're completely different, aren't they, in their focus, is coming from a sort of a perspective of wanting to understand where we are and what the need is. So it's very different in each of the projects, but I think a journey from your huge amounts of efforts trying to reach lots of young people, not just the ones that turn up typically who feel very vocal and able and find their way to these kind of participation forums, but young people who are, you know, in communities, very small communities, who may not sort of have the transport or the, you know, or the awareness necessarily that these things can be something they can be part of, trying to work really hard to understand those challenges. I think that's so important, and starting with the voice of the young people and really committing to that, to changing what you're doing on the basis of what you've heard. I think, you know, it's all very well to tick the box, but that's not what we're trying to do, and it's not going to be the answer in terms of making better support, is it? And I think, June, I was just really conscious of your starting from the point of thinking about what's the problem we're trying to tackle here, where are the barriers, and I know a lot of work went into understanding who were the groups who might have been missed, like boys and young men, for example, who may not self-refer, but also, yeah, who are these groups who, you know, may not turn up to a service, may not navigate their way there, or maybe below that threshold but still needing support. So really thinking about where's the space we're really trying to work, and how can we design something that fits that space. That feels really important. And I think, Julian, I know we had lots of conversations about this work before it started, but that real will to, some frustration, I think, that we kept seeing data that was telling us that girls and young women were really struggling with their mental health, and seeing that really all those figures about increasing mental health problems in young people, a lot of that was driven by escalation in girls and young women, and that not being sort of specifically paid attention to. So being able to point to that, but also point to the other inequalities, and particularly for those intersectionalities and those minoritized groups. But as you say, so really then focusing on, this is the problem we really want to think about carefully. What's the way we can get to that? So I think that's what I've really appreciated from all these projects, this sort of real kind of commitment to not sidestepping the difficult things, but making sure that's the focus of what we're doing. Yeah.
Thanks, Jess. That was a really good, fulsome kind of umbrella answer there. Thank you very much. So, June, I've got several questions for you. So I'm going to try and cherry pick from them. So the sort of first part of this question was very much around sort of where does the intervention, the Discover intervention, and all of that kind of come from? How did that come together? And their kind of second part to that question was around the young people who self-referred and whether they had comorbidities around anxiety and how this was kind of managed within the process. So two very different parts to the same question there. And I've got more like this coming. So see how you get on with this one.
Okay, let me have a go at the first. The program was a kind of joint effort. I had developed a program for adults, but when Irene, who was an adolescent psychologist, was consulting with her young people, they just essentially decided what would be the most important things they wanted to learn about. So basically, it was the young people who actually said, yeah, I want to learn about various things. So, for example, sleep became quite an important area in the program. Because young people often do have problems with sleep. And they also wanted the program to be much more engaging, so that it didn't bore them, basically. And so it was very much about trying to make the program very, very lively. And that was very much what the young people said they wanted. They also wanted there was a half-hour session before the workshop program itself, so that they could actually get to know the person running the workshop. And then there were also follow-up sessions after the workshop itself. So it wasn't just one day, but there were supporting sessions before and after. And so that very much came from the young people. So it wasn't us saying, this is what the young people need. It was the young people telling us what they wanted and also telling us the name of the program. So they named it Discover. We didn't give it that name. We would have given it a much more boring name, but they gave it Discover.
I like the name they picked, June. I'm going to be honest. I think it works really well. I think we should stick with it. Okay, that's really great. And then the next question was very much again around the young people taking part, and sort of how they were sort of feeling while they were taking part, and were there any that were not necessarily in crisis, but that were experiencing struggles, and how that was potentially managed alongside the intervention and the research and all that sort of thing, and if there were any kind of inclusion exclusion criteria that came up around that in the workshops.
No, we didn't have any inclusion or exclusion criteria apart from if somebody was actively suicidal, in which case we thought it wouldn't be fair. If they had problems during and after, usually the mental health support team person would be aware of that. That would be picked up at the pre-workshop stage. And then there would be decisions made about what next and whether to refer the person on to the specialist service through the schools. So it was the school that very much held that responsibility. So we didn't hold that we didn't in the trial hold that responsibility. It went back to the schools. And if they needed more specialist help, then we would suggest that to the schools.
That's great. Thank you, June. I'd quite like to give the speakers a bit of a break now. So I'm wondering if I could go back to Emily and Kate and see if you've got any other questions. We are coming towards the end. So one each, maybe, if you've got one, or any other thoughts that have come up while we've been talking.
Yeah, it might be another one on the BEST trial, actually. I think I was quite surprised, actually, by the amount of young people that were willing and happy to participate in it in the school setting. I just think back to my time at school, and the thought of someone seeing you waiting outside the counsellor's office was just humiliating, and I very much wanted those things to be separate. So I guess I found that surprising. I suppose I have a question on where it's sort of self-referral and it's quite like a low bar for intervention. Do you think this would be the kind of thing that could be useful for integrating more into the curriculum, so more sort of like coping mechanisms and strategies before problems arise, or do you think it is sort of interventional in nature?
I mean, it's a tricky one in the sense that there was a very large study where they tried to integrate mental health into a curriculum, and they just didn't find that it worked very well. And the conclusion from that study was that it was just important for the students to decide whether or not they were going to use the techniques. And if they weren't going to use the techniques, then that would actually just bring the effectiveness level down. So I think the whole concept of choice is hugely important. And the way that we've done it has been to actually make mental health more attractive. Because we've taken the approach of trying to position it as a kind of problem of living as opposed to a mental health problem, then it hasn't felt so stigmatizing. And I think that's just a very important point. So the research workers would go along to a school assembly and then invite students to come along to a further information meeting if they might be interested. And then they would get more information about the trial. And we were surprised by how many people did come up to the information meeting. And at one stage, I was going to reply to this when there was a question about challenges. We had so many people come forward that we didn't know what to do. I need to say this also coincided with COVID. But we had, I think in one school we had something like 38 people or something. And we were saying, but we've only got space for 15. So anyway, we did sort that by just deciding to run 2 workshops. We just had to expand the space in the workshop. But no, I think there is something about you can actually make an intervention attractive and engaging. I think the kind of danger sometimes might be that it becomes too ordinary, so that people might say, "Oh, I've got I don't know, a sore toenail or whatever," and then come along. And it's something about helping people just recognize that they may or may not have a mental health problem, and they can choose or not choose to come forward to that kind of intervention. So I just think young people can make that decision. I don't think we need to mollycoddle them, and we don't need to be overprotective, but we can just make it a bit more accessible. Does that answer your question?
Yeah, that's really interesting, and yeah, makes a lot of sense. Thank you.
Okay.
Thanks, June. Kate, did you have a final question for anybody or everybody?
Not really a question. I found it interesting listening to Emily, because I know a lot of pupils do kind of worry about being taken out of lessons or waiting in the wrong bit, the counsellor's area or whatever, and the stigma that's attached to it. But I suppose it goes back to what Julian was saying as well about creating schools that are inclusive environments and kind of trying to normalise all kinds of different experiences and different communities, and just kind of celebrate that a bit more, and just make them safer spaces, I suppose, for children to be in. But yeah, I think it's really exciting what might unfold in the next few years.
Thanks very much, Kate. So there's an interesting point in the Q&A that's kind of been raised that I'm not sure we can quite answer, which is kind of around the fact that, we do a lot of research in different settings, particularly with school age people, and there's various interventions that we try out, and people are able to, self-refer and join into different studies. And they were kind of posing the question about what are the odds of some of these people being involved in multiple studies or having gone through multiple interventions, and if that's potentially had an impact. I suppose the reason we may not be able to answer this is that we just don't necessarily have all the answers to what people could have been involved with. But any thoughts on this, particularly, I guess, more around the longer life of interventions and some of the sustainability elements and sort of future of this work, might be the direction we take this sort of discussion point, and that's open to anyone, but I'm kind of looking at Jess and Julian right now.
I can have a go at that one. So there's probably a number of ways to answer that. I mean, I think when we're in trial conditions, it's a bit easier because we can do one of two things. In trials, we're either trying to control for things or we're trying to measure them. So for example, when we do some of our trials in schools, we've asked schools the kinds of things that they provide typically or are providing currently, to give us a sense of how much overlap there is between that and the intervention, and we'll ask them that at various intervals throughout the trial, so we get some kind of sense of what young people have accessed. Often there'll be an economic component to what we do as well, and often that involves collecting information from young people themselves about services they've accessed. So in theory, that is available through those means too. And of course, with randomized trials, the whole point of random allocation is that some of those things kind of fall out in the mix, because we assume that they're random across the intervention and control arm as well. So that's kind of how we manage it. But I think it does become incredibly difficult. It's actually quite hard to ask people what they have accessed as well. I don't know if anyone else feels the same, but certainly if someone asked me how many times have I been to the doctors in the last year, or I actually, it all blurs and you're not quite sure. Sometimes you're not quite sure what service is what, particularly if you're a young person. It's not clear what route you've got something from potentially. So sometimes that's less clear. And also, yes, you're right. The longer the follow-ups become, the more randomness is then added in, and the more, if people are experiencing ongoing challenges, they might have that additional support added later, which we can try and capture, but probably never perfectly reflect in our research. So it's always something to be mindful of, but probably something we never have a very perfect perception on. But yeah, maybe others have thoughts to chip in.
I think it's a really interesting question, and it poses that kind of, how do we balance kind of not over researching groups, avoiding some of the tangles you were just referring to, Jess, while still giving, what's been so clear from today and what June was just talking about, giving young people that choice. If we don't look at these different programs that work in different ways, do we kind of risk falling into that trap where we kind of think one thing works for everyone, but we don't have a kind of suite of different support options available for different people? So yeah, I think I don't know if I've necessarily got anything to add, but I think it's an interesting question.
Thanks, Julian. Yeah, definitely important point to remind ourselves of. We are out of time, I think. So that's been a really interesting discussion. I want to thank everyone of the speakers and all of our panelists, particularly Emily and Kate, for your insights. It's been really helpful. Thank you. Also just want to thank the team who've been supporting. So to Maisha and Magdalena for helping us out today. Thank you so much. Thanks to all of you for joining, for your attention, for your questions. It's been great spending time with you. You'll be directed to a kind of feedback form as you leave. If you please could give us some feedback. We're always trying to, we do these about 3-4 times a year. We're always trying to sort of adapt them and make them as accessible and interesting as possible. So if you've got thoughts as to how we can improve, that's your chance to do so. So yeah, thanks once again to everybody for joining, and hopefully we'll see you again soon.